Yes. Good morning, everyone. I'm Dr. Ananya. I'm rotating with Dr. Bernad for the month of June. And the topic I'm going to be discussing with you today is neurological manifestations of long COVID. The reason I chose this topic for our discussion today is because neurological manifestation and post-COVID in itself is the current healthcare dilemma, and it is uncharted territory for the most part. So as doctors, I think it's important that we educate ourselves on what we know so far so we can help in contributing to better understanding this disease. Post-COVID is a multi-system disorder. And right now, neurological manifestations is seen in more than 1/3 of the population. And it can be involvement of the central nervous system or the peripheral nervous system, and also the autonomic nervous system. Post-COVID, there is no specific term as yet, but it is known as long-haul COVID, or long haulers is what the patients are called. Long COVID, post-COVID syndrome, and post-acute sequelae of SARS-CoV-2 infection. I would like to discuss a study before we start off. The study was done to assess the cerebral PET scan in patients that was suffering from the cognitive impairment that is linked to COVID-19. The study is Cognitive Decline and Brainstem Hypometabolism in Long COVID, a case series that was conducted in Paris by Hugon and his team. So they referred to 3 cases of patients that had COVID-19 infection. It was confirmed with the PCR, and they all presented with cognitive impairment in the future. The first patient is a 65-year-old woman. She was hospitalized in the ICU with acute respiratory failure. She was PCR positive and was on a ventilator for a few days. She had various comorbidities. Her neurological sequelae developed few weeks after she was discharged from the hospital. She presented with memory problems, poor concentration, and inability to stand. On examination, she had hypertonia of her right upper limb. Her MRI and other neurological examinations were essentially normal. MMSE was performed on her, and she scored 29 on 30. The second case is a 70-year-old man. He had fever and dyspnea on exertion and sweating. He was confirmed to have COVID by the PCR test, but he was not hospitalized and he recovered within 2 weeks. He had hypertension as well. His neurological sequelae developed 3 months later, and he developed cognitive impairments as well. He had memory issues, executive and language deficits. His MRI was normal as well on imaging, and he scored 21 out of 30 on the MMSE. The last case that we're going to discuss is a 42-year-old woman who had fever, myalgia, dyspnea, and anosmia. She was confirmed to have COVID with the PCR test, and she recovered within 3 weeks. This patient was not hospitalized as well. She developed her neurological manifestations 5 months later, and she began having the cognitive impairment as well. She had memory issues and abnormal executive functions. MRI was normal again, and she scored 25 on 30 on the MMSE. All of these patients had the FDG PET scan done, and as you can see here, they have hypometabolic regions in their scans, and most of the thing that they have in common is the hypometabolic region in the brainstem. Now, the question that we may have now is the brainstem really involved in COVID-19 cases, or is it just a coincidence that we see it in these cases? Another study was published recently. It was a neuropathological study. And in that study, they studied patients that had died in nursing homes, hospitals, and at home, who were confirmed to have COVID-19. And the histological study showed that they have activated microglia and cytological T lymphocytes in the brainstem and the cerebellum region. So that also correlates to the fact that the brainstem is affected and is involved in the neurological manifestations of this disease. The second question is, the brainstem is involved, so now what? How is this causing cognitive impairment in these patients? The locus ceruleus is a very important nucleus that is in the brainstem, and apart from its involvement in alertness and sleep-wake cycle, posture, and balancing. It also has projections into the prefrontal cortex and the hippocampus, which then it manifests in the presentations as people having the behavioral problems that we're seeing, cognitive impairment, problems with attention, their reaction and the behavior to stress, and also executive and decision-making capacity. Now, moving on, I'd like to give you a brief overview of the symptoms that neurologists are seeing all over the world with patients that are presenting to them. I'm going to divide the symptoms into central nervous system and the peripheral nervous system. So starting with one of the most common complications that people are coming with is headaches. Headaches that the patient report are various different types. If the patients often already have migraine and different kinds of headaches that they're experiencing in the past, these headaches change in the presentation. They often, the medications that they used to take for treating their headaches don't work anymore, and they have persistent headache that is not relieved with sleeping and the techniques that usually would work for their migraine headaches. Sleep disorders is another common presentation that people have. It is on both sides of the spectrum. They initially are very tired, they have fatigue and daytime sleepiness. They have a change in their circadian rhythm. And on the other side of the spectrum, they have insomnia, they have difficulty falling and staying asleep. Now, the most common symptom, brain fog or cognitive dysfunction. Patients often come present with inability to concentrate, inability to multitask, and often people that were involved in very cognitive roles in their workplace could not function anymore. Lawyers couldn't do their work anymore. And like we had a patient that came in and she was a secretary, and she said that she was used to dealing with multiple phone calls a day, multiple people talking to her, and now she couldn't concentrate on different conversations at a time. She couldn't concentrate on different tasks. So that's how they present with brain fog. They often walk into a room and they forget why they came, and they have short-term memory problems as well. Fatigue is another common symptom that they present with. It is often when they have the COVID-19 acute infection itself, and then it progressively gets worse and they essentially heal from COVID, as in they don't have fever and they don't have the breathlessness, but they continue to have the fatigue. In some patients, it is so severe that they can no longer go back to their jobs, they can no longer care for their family or themselves, and they're essentially tired the whole day. Another common symptoms that we see is mood disorders. Patients that already are dealing with depression and anxiety present with worsened cases. And again, their medication is not able to help them get back to their resting or basal level. And patients that did not have anxiety and depression in the past have developed anxiety. It is related to the disease and the pandemic itself, but patients have also developed generalized anxiety disorders post-COVID. Dizziness and dysautonomia is conditions that is related to the autonomic system. And there are studies that said that fatigue is also the most common presenting symptom for dysautonomia. Other dysautonomia symptoms would be the positional tachycardia that patients have. They have fatigue and they have dizziness. The dizziness that they have can be just unsteadiness, unable to walk, and just feeling tired, or they have the full-blown vertigo symptoms where they are unable to walk, unable to stand, and are essentially bedridden. The peripheral nervous system. I've heard a lot of cases of anosmia, hypoosmia, or altered sensation in smell. We have heard interesting cases where patients present with they claim that they can they can smell smoke in their house and often go and check in their kitchen, and their family members reassure them that there is no such smell around them. So we know that altered sense of smell and altered sense of taste as well is a common presentation that people present during their acute COVID-19 infection, but like I mentioned earlier, they recover from the acute infection, but they still have altered smell and taste dysfunction months after the recovery. Muscle weakness and myalgias, they also go hand in hand with patients that complain of fatigue. They have muscle weakness that presented out of the blue it started insidiously, but it would be weeks after they recovered from their infection. So patients would present to the clinic with just muscle weakness, and on further questioning, we find out that they had COVID-19 infection in the past few weeks or months. Hearing loss and tinnitus is also one of the symptoms that they present with, and they can either come with isolated hearing loss, and on further questioning, we find out that they have the whole constellation of fatigue, dizziness, and other accompanying features. Hypoesthesia, dysesthesia, they have tremors, and it's often a traveling type of sensation abnormalities that move all across their body. It's on and off, and it, like the other symptoms, starts weeks after their recovery from the COVID-19 infection itself. So let's discuss the pathophysiology. We still are discovering new mechanisms in which the virus itself is attacking the brain, and also how it has lingering effects months after the patients have recovered. As we can see here, the top part of this picture would be how the acute COVID-19 infection would present. The COVID virus can reach the brain through hematologically through the blood, or it can go through the transsynaptic route, and it binds to the ACE receptors on the endothelial system, the smooth muscles of the blood vessels, and the blood-brain barrier, and the neurons itself. So they penetrate the blood-brain barrier, and this causes the tight junctions in the epithelial cells to disrupt, which further lets in infected lymphocytes and infected leukocytes to enter the brain. And once it enters the brain, this then activates the microglia, which is a chain reaction which leads to demyelination in the end. This will also lead to platelet activation and adhesion, and then this disrupts the blood-brain barrier and would also increase the thrombotic risk that we often heard with COVID-19 patients. Now, coming to the chronic infection. Chronic infection has various different mechanisms that has been proposed, and the most common one is the neurodegeneration that happens from the activated microglia and the demyelination. Also neuroinflammation, that is the infected leukocytes and enters the blood-brain barrier, and also oxidative stress in the ACE inhibitor rich areas in the brain that are highlighted in this little brain scan down here. It is the somatosensory cortex. You can see the brainstem here involved here, the hypothalamus, thalamus, which would cause all of the dysautonomia. It involves the pons medulla that causes all of the cognitive impairment, and hippocampus that we just discussed. Cerebellum with the balance disorders. So they do present with a wide variety and often present with multiple different areas of the brain affected at the same time. So now I want to talk about how we can aid in diagnosis. As of now, there is no specific criteria for diagnosing COVID-19, post-COVID syndrome, and the neurological mechanisms, but there are some that can help us characterize the symptoms that we're seeing. This is one of the symptoms this is one of the categorization that has been proposed. It is symptoms that persist from the acute phase and their first treatment that continue for months after they have recovered. The symptoms that are associated with the new disease, late onset symptoms, are a consequence of COVID-19 that arise at the end of the acute phase and impact on previous pathology or disability. In December 2020, NICE published a guideline in the British Medical Journal, and their guideline helped us distinguish the acute COVID-19, which could last up to 4 weeks, ongoing symptomatic COVID-19, which would be 4 to 12 weeks, and the post-COVID syndrome, which are signs and symptoms that develop during and after COVID-19 compatible infection. In this criteria, they did not need a PCR positive confirmation, just COVID-19 compatible infection was okay. And this would continue for more than 12 weeks, and it cannot be explained by an alternate diagnosis. So in conclusion, the key message or the purpose of this discussion is urging physicians to keep an eye out, know the symptoms that we have already discovered, and watch out for the symptoms that we don't know of as yet. Know that the patient present with a wide variety of conditions, and we often have to prod them and ask them if they ever had a COVID-19 infection. So we have to ask them if they had flu-like symptoms that would be worse than a common flu. There is an urgent need for establishment of an operational long COVID case definition. We need stringent documentation of their signs and symptoms, risk factors, and ongoing complication, comorbidities that we require for a systematic approach and management of these long COVID patients. Since long COVID is a multi-system disease and often affects multiple systems in our bodies at once, so it's a multidisciplinary collaboration that is essential to provide comprehensive and integrative long COVID patient care. Early neurorehabilitation should be recommended for patients experiencing long-lasting neurological symptoms after resolution of their acute COVID infection. Although there are neurological therapies for long COVID, preliminary data suggests that supplementation with antioxidants may hold some therapeutic potential, because oxidative damage is what they're proposing for the long COVID symptoms. These are the references and the articles that I looked through to gather the systematic review on the current knowledge that we have on post-COVID neurosymptoms. Thank you so much.
Thank you very much.
Thank you very much.
Dr. Bernad, any comments?
Yep, I think it's a very important topic. And Dr. Stein and us and the young doctors over the last 2 years have been aware of the complications. We've called it the long haul syndrome and long COVID and post-COVID, et cetera, et cetera. And it seems like many people develop various symptoms, including the headache and the dizziness and the decreased smell, the loss of smell, and so forth and so forth. But I don't see anything that really is unique to this particular virus, this coronavirus, because we see these symptoms virtually with every infection. And if you look at, every year we have about maybe 100,000 people who die from flu. Or you look at the flu epidemics, you look at any kind of viral infection, there seems to be a sequelae in some patients. So it doesn't surprise me if the coronavirus also has some sequelae. The problem that I see is how do we know that it's from that particular viral infection? I'm always we basically always ask about infections, the COVID, and the post-COVID, but I'm always puzzled as to, do we really know that this is from the infection? Also, the other side of the issue is the vaccination, and does the vaccine and the subsequent jabs. Some people have taken 5 vaccines now. Do you think that may cause some residual symptoms as well? A few years ago at the NIH, we saw patients who received a flu vaccine and developed numbness and tingling, paresthesias, and developed Guillain-Barré. And that was kind of scary because a lot of people received the flu vaccine, including myself. And then what happens when you have a lot of vaccines for all these other illnesses and diseases? Is there a cumulative factor as well? So it's a very nice, I think you're bringing it to our attention this night, but I'm not sure if there's anything specific in terms of take home that makes it a definitive diagnosis. Do you think that we should be doing some kind of brain scan, like you started off by showing this PET scan, positron emission? do you think that the scan is indicated in seeing some of these patients with non-specific symptoms after having had maybe COVID?
I think because they have symptoms like cognitive impairment that isn't essentially what we call a major symptom, but it has an impact in their life. So
Yeah.
identifying a focus on the PET-CT would give them at least a diagnosis, and then you can get rehabilitation.
It's
from
very
there.
non-specific. So
Right.
on the COVID, you'll see abnormal brainstem findings,
Right.
locus coeruleus, and so forth. So I don't know, and it's expensive. You know, the PET scan may be
Mhm.
$3,000-4,000. So I'm not sure if we should do it on every patient who has these symptoms, but that's a good point. That first study, when was that published? The French study, 2021.
Mhm.
I don't know if I really believe that study. Also, the mini mental status showed very low in the middle
Right.
patient.
Right.
I'll actually demented. The patient was demented.
Mhm.
How did they separate another cause of dementia that we see
It
from the
was
COVID?
essentially patients that didn't have dementia before, and the dementia, the start dementia that we see developed just in a few months after the infection. So it wouldn't have been dementia that he
Yeah.
had.
Well,
before.
I'm not convinced, but
Right.
I'm not convinced about the 3 patients. It's kind of
Mhm.
interesting, but I'm not totally convinced. Many of the patients that we see with the long haul,
Mhm.
the symptoms are very subtle, actually more like chronic fatigue syndrome, which is another condition that we really don't know what causes it. There's all kinds of studies, but fibromyalgia is another condition. There seems to be a group of conditions that we see as neurologists that we don't really know what the etiology is. And I would put this post-COVID group into that category. So chronic fatigue, fibromyalgia, and now post-COVID.
Mhm.
I think it's all the same. I'm not sure what the underlying etiology is.
But you're
thank
gonna
you.
have to manage these patients, right? And
Yep.
you're gonna have, they're gonna be applying for disability. And you're
They're
gonna
all-
get a lot of work taking care of these patients for the next few, and we can't help them
Yeah,
necessarily.
they have clinics now.
Yeah.
Dr. Stein and I talked about this 2 years ago, that we should set up like a post-COVID clinic. Well, many of our neurology colleagues have already set up these clinics, and they're being filled up by these people all looking for disability. And I think it's a mess. I don't think we have
Your microphone is off.
any kind of any
Microphone is still off. Okay.
the symptoms are all 3 of the neurological elements, including central nervous system, peripheral nervous system, and autonomic nervous system. It's like everything's there. And for me, it's very hard to actually tease out anything specific. You're always looking for a specificity. You're looking for a sine qua non. You're looking for smoking gun. You're looking for something that's specific for the disease. I don't see it. I just don't see it at this point. I just see it as part of this non-specific fibromyalgia. And, I've studied these. I've never found a true explanation for fibro or chronic fatigue or any of that. They all have the same things. They have central nervous system. They have depression. They have sadness. They have they can't think. They have fog. They have.
Dr. Bernad, so you know how we have like linked Bell's palsy, a neurological condition, with a herpes virus?
Well, but that's not even certain.
Yeah, so
Yeah.
would that be how we're gonna?
The Ramsay-Hunt syndrome is very rare.
Mhm.
The Ramsay-Hunt, where you see herpetic lesions in the ear canal, that's like 1 out of 100.
Mhm.
And so most 99 of these patients, we don't even know why they have Bell's palsy. I mean, I have some explanation. The traumatic ones where you hit the canal. The canal is small and it breaks and then it squeezes the nerve. You can understand that, but that's also rare. So in the majority of our patients who come in with seventh nerve palsy, so-called Bell palsy, described by Dr. Bell, who was a physician, I don't know what causes it really. I mean, we have argument. Multiple sclerosis can present with the Bell palsy. Viral infection can present with Bell palsy. It's one of the more common palsies that we see. But I don't know if there's anything specific to say that it was caused by the COVID or whatever.
What if we have that links, like suppose Guillain-Barré syndrome to post-infection from gastrointestinal or respiratory? How we link those two? Can we not link the COVID-19 infection with these neurological manifestations?
I don't think we can. The Guillain-Barré situation is one of these other ones where we're not certain what's going on. I mean, you ask about infections, previous infection 2 weeks before, like diarrhea or gastrointestinal, or but many patients don't have any of that. And then you ask about vaccinations, and many patients did not have a vaccine. They weren't vaccinated prior. And then you ask about other infections. So like the lady, for example, that we saw yesterday, she had Guillain-Barré. I took care of her at Alexandra Hospital, and I did the spinal tap and everything. It was a classic Guillain-Barré. She was in the hospital for 4 months, but she didn't really have any infections beforehand. This was 38 years ago, way before the coronavirus. But you know, coronavirus has been around for a long time. There are thousands of viruses. Yeah, they may have had some kind of virus and then an odd reaction neurologically, and there you go with Guillain-Barré. I don't think we have the answers, but it's a good topic, a research topic for you. You're going to Mayo Clinic now, so maybe try, see if somebody's working on that. Like Dr. Engel may be working on it. Peter Dick is working on it. He's very famous in peripheral nerve disease. Were you able to listen to her talk? It's very good.
No, I was.
The post.
I think I will watch the
post-COVID.
But yeah, I know that she's talked